in furthering research and progress. So if you want to go, now is the time. The following speaker has a national following, and we're pleased to live stream her presentation to the worldwide CF community. We're pleased to have Dr. Alexandra Quittner join us. She's a professor of psychology and pediatrics at the University of Miami. Dr. Quittner has focused her research on CF and other rare diseases. She is deeply committed to researching the impact CF has on the emotional well-being of those diagnosed with the disease, as well as parent caregivers affected by CF. Dr. Quittner's international study of anxiety and depression in the CF community has had a national impact upon mental health assessments of our CF community in the U.S. To those of you watching from afar, welcome. To those of you in the room, please join me in welcoming Dr. Alexandra Quittner for her presentation, There is No Health Without Mental Health.
Thank you. Thank you so much.
This is what we use to advance. And then I'll get you. You can? Let me get you.
Do you have a laser?
It's on here or right there.
Did it work?
Is it working?
Not really, no.
Okay. Let's see, where did you go? You are there. And you're ready.
First of all, I'm just so thrilled to be here. It's so wonderful to see this community, CFRI. I came and gave a presentation a number of years ago, and it's wonderful to see it strong and thriving at this point. I want to thank CFRI and the conference organizers for inviting me to speak today about what I feel is such an important topic in CF. There is no health without mental health. And I wanted to give you just a few minutes of background on myself. I got my PhD in Canada, and when I was rotating through the various pediatric specialty clinics, diabetes, asthma, epilepsy, and then I came to cystic fibrosis. And that really convinced me that this was the group that I wanted to work with. The challenges psychosocially were so interesting and difficult to deal with. I discovered at the time we had no disease-specific quality of life measure for CF, and so I spent the next 10 years developing the CFQR, which our previous speaker mentioned, and is featured in almost every clinical trial in the world to measure whether respiratory symptoms improve given one of these medications that your families and your individuals are trying. I also realized that adherence was a central issue in CF, that this regimen, as we added on to the regimen, it had become so complex to manage that it was challenging for children, adolescents, and adults to fit these treatments into their daily lives. And so I launched a number of studies focusing on adherence, figuring out ways to improve adherence and fit those treatments into daily life. And so the other piece of it, which I guess is more traditional for a psychologist, is this idea of health and mental health and the integration of those two. So you may have seen the plenary session at the North American CF meeting last October. To be honest, it was the first time ever that we had a plenary devoted to mental health. And I have to say that we were all thrilled in the community that this happened. And the premise for our framework is, first of all, that well-being includes both physical and mental health. In other words, we really need to integrate these two to have the very best health outcomes for our patients. So we really want to treat the whole person. And here I've tried to show this in a diagram. It's a little bit hard to see. It didn't come out exactly right. But health and well-being are right here in the middle, and they bridge physical and mental health. And we need to address both of them. The second premise is that we do have reliable and valid tools to measure these symptoms of depression and anxiety. And those tools take about 5 minutes. And so we really have a good way to assess and identify whether someone is struggling emotionally. And that is the very first step we know in being able to address an issue, is to first measure it and identify it. And the third premise is that if you have a chronic illness, whether it's cystic fibrosis, diabetes, non-CF bronchiectasis, or you care for a child with a chronic illness, you are more likely to have symptoms of depression and anxiety, and that these are a normal response to a very challenging situation. So often we think about mental health as an abnormal level of functioning. But this is actually turning that all on its head and talking about mental health and symptoms of depression and anxiety as being both very common and very normal as both parents care for their children and as children, adolescents, and adults try to manage this chronic disease on a daily basis. And finally, it's very important to recognize that when you do feel depressed or anxious, that it will affect your behavior. And I'm going to show you some slides later, really directly showing the link between depression and worse adherence to our medical regimen. So we know, and we had a wonderful speaker that we just listened to from Minnesota, we know a lot about this cycle, the impact of CF, of obstruction, infection, and inflammation. We've studied that a great deal, and we know a lot about that. But what we haven't looked at is really how this cycle also affects mental health, symptoms of depression. And finally, we need to look at these links between mental health and adherence, because adherence is a key to improving our health outcomes going forward. And finally, what's really interesting is, of course, we know adherence can influence reducing infection and inflammation. We know if you are doing your treatments more regularly, your health outcomes are better. But interestingly, I'm sorry, I have to go back. Interestingly, the last arrow that's really interesting is that we think depression, oh, I'm sorry about this. Oof, I apologize. That depression may also independently cause inflammation. So in other words, independent of your lung function or your disease state, we're also developing data to look at whether depression itself is a cause of inflammation. And we're studying this in the Mountain West Consortium. Dr. Ted Lee has a study that's examining this at a number of CF centers on the West Coast, looking at inflammatory markers and measuring depression at the same time. We do know that depression independently can cause inflammation in cardiovascular disease and asthma, and it's possible it does that in CF as well. Now, I can go on and talk to you about some of the effects we know that are mental health related. If you're depressed or anxious, you're less likely to come to clinic as you want to. You will have more pulmonary exacerbations, and we know that those inevitably cause a decrease in lung function. We know that depression and anxiety can cause decreases in lung function and BMI, and finally, we've established that it also affects quality of life. So there are a number of very important effects that mental health have on behaviors that are really important to manage the disease. We know that individuals with chronic conditions are at greater risk for symptoms of depression and anxiety, regardless of which chronic disease it is. This is very well established. And we also know that parents are at elevated risk caring for a child with a chronic disease. And we know in CF there are single center studies that have shown this. I have done some of the studies showing that soon after the diagnosis, that's an enormous period of change and challenge. Parents often feel overwhelmed and alone. We know that depression can come at different points in the disease. First hospitalization, first diagnosis of CF-related diabetes. So the international community decided to assess the prevalence of these symptoms on a large scale. This was called our TIDE study, and it really fits your theme of riding the wave. And we named it TIDES because at the time, hypertonic sailing was just approved, and you know that they sort of discovered its beneficial effects with surfers. So it was a beautiful sort of moniker for the TIDE study, the International Depression Anxiety Epidemiologic Study. That's a mouthful. So we started to conduct this study on less than a shoestring budget in the United States and in 8 other countries in Europe. So these are the countries that we study. Of course, 45 centers in the US and 8 other countries across Europe, such as Denmark and Italy and Germany and the UK. So this was a huge effort that was really grassroots. We gave 2 brief measures of depression and anxiety, background and medical information. And this study took us 10 years. I have to say this was a real work in my heart. This was something that I was dedicated to doing for a very long time, and I'm so glad that we all persisted. We screened 6,088 patients in 9 countries and 4,102 parent caregivers. So this study, I think, has had a really important impact on the CF field. We published it in Thorax. So here you see that adolescents with CF using a clinical cutoff score on depression were about 10% of those adolescents scored above the clinical risk cutoff for elevated symptoms, close to 20% of adults, 31% of fathers, and 37% of mothers. And these rates were about 2 to 3 times higher than we see in the regular community. This is the cutoff score for anxiety. Here, these are even higher. 22% of our teenagers and 32% of our adults scored above the cutoff on anxiety. And this was statistically significant. In other words, that transition to adulthood can produce more symptoms of anxiety as you're worrying about your future. Look at these rates among fathers, 36%, and mothers, almost 50%. And this, again, is statistics. So mothers reporting more symptoms of anxiety than fathers, but fathers are very elevated. And I think one of the messages here is we need to pay attention to fathers as well as mothers. This was the other amazing thing we could study. We had 1,130 parent-teen dyads. Within the same family, we had a mother, a father, and an adolescent with CF. And we could study whether there was a relationship between the parent and the adolescent depression. So adolescents were almost 5 times more likely to report symptoms of depression above the cutoff if the parent was elevated. And the same thing for anxiety, 3.5 times more likely if a parent was anxious that their adolescent would score in the elevated range. And this highlights the importance of screening parents. And this was a huge issue when we launched the international guidelines to address the elevations in the TIDE study. There was a lot of reluctance to screen parents in a CF clinic. You might ask why? Well, one of the reasons is they feel their identified patient is that infant, toddler, adolescent with CF, and their identified person is not a family or parents. And we argued from the pediatric perspective that we know how parents are feeling directly affects how they're able to parent their own child and how the child is feeling. So we argued strongly for the importance of screening parents. And as we've been rolling out this screening across the United States, parents have welcomed it. So this is a very important kind of milestone. So in conclusion from the TIDE study, there's a high prevalence of anxiety and depression in people with CF and caregivers. It's 2 to 3 times the prevalence in the general population. And it has effects on adherence, on health outcomes, on being hospitalized more often, using more healthcare resources. All of these are well documented. Parents were also elevated, and we need to pay attention to them. And the concordance between parent-teen symptoms suggested, yes, we need to screen both individuals and parent caregivers. I wanted to show you just a couple of analyses that Mike Schechter ran on the TIDES data in the US. We had 1,902 participants, and these are the centers across the country that participated. He tried to identify risk factors for depression and anxiety in the TIDES data. And I wanted to go through this really quickly, but here are some for depression and anxiety risk factors. This is for adults. Divorce in an adult patient was related to depression and anxiety. Now remember, he's linking it to our registry data, so he's able to ask some very interesting questions. Interestingly, lung function was not related. So in other words, people with very good lung function, moderate or poor lung function, reported these symptoms regardless of their level of disease severity. Interestingly, poor nutritional status was related to depression. And anxiety, as I mentioned earlier, was more likely if you'd had a pneumothorax or hemoptysis that occurred in the last 6 months or you were listed for transplant. What are the parent risk factors? Depression was less likely in mothers, but not fathers, who had private insurance. So in other words, low socioeconomic status can also put you in a higher risk category. Lack of employment was related to anxiety and depression. That would make sense to most of us. Lower education was again associated with depression in mothers and fathers, and also to anxiety. So these are some of the risk factors that he identified. For depression, he also said if you're entering adulthood, you're more likely, we saw that adolescents were less depressed than adults. Medicaid status, marital status, underemployment or unemployment, poor nutrition, and then having any of these kinds of treatments for these kinds of symptoms. For parents, it was really patient age. Interestingly, fathers were far more depressed when their kids were younger. I think they had a lot of worry, a lot of sense of what's my role in caring for this child. And I'm going to talk a little bit about that later, that importance of both mothers and fathers doing caregiving roles. The Medicaid status for moms was a risk factor, unemployment, lower education, then of course being treated for these symptoms. This is for anxiety. Being female was more likely, and again, underemployment or unemployment, being on the transplant list, recent serious health events, and then comorbidity. And for parents, it was, again, fathers. They were more anxious when their kids were little, and maybe in adolescence, they sort of turned sort of mental well-being over to their adolescent and pulled back a little bit. Again, education, and then having those symptoms already. So what do we do about depression and anxiety? Well, what we did first was establish a guidelines group, and we worked on the literature and reviewed it for about 2 years in Europe and in the United States. And this is a picture of all the participants. We had psychiatrists, psychopharmacologists, pulmonologists, psychologists. The whole multidisciplinary team was represented, including a person with CF, Chris Baum, you may know him, and parents of children with CF. There's Kathy Sabadosa, in case you know her. So this is a hard diagram to read, but this is really what we came out with in thorax. These are our guidelines, and the figure's hard to see. The idea is once a year, we will give you a screening tool, PHQ-9, GAD-7. In my clinic, we're doing it on an iPad. It takes less than 5 minutes to administer. It scores automatically, and it stores it in a database we can look at. If you are mild or in the mild range, all we'd like to do is check in with you and say, how are you doing? Do you need anything? Can we offer any resources that might help you? That's it. And maybe give you a pamphlet or some education about symptoms of depression and anxiety. Most people will score in this mild range. And so for most people, it's just a check-in. It's a way for us to know, let's check in about how you're feeling, how you're doing. So annual screening for all parents with infants up to through age 17, and screening with children beginning at age 12 through adulthood, 1 time a year. Then if you're in the moderate or severe range, we would do a further clinical assessment, and then we would like to either refer you, if you're a parent, to someone who could use evidence-based treatments to address these symptoms. Or in your CF center, we're hoping that your social worker, or now we're getting more psychologists on board, could provide some brief counseling sessions to you. And you know the CFRI is also addressing this issue in terms of depression, and I'll mention that at the very end. You can do online support services. There are kind of telehealth sessions on cognitive behavioral therapy for depression. And then we would check back in with you to see if the symptoms are better, and then simply screen every year. Oh, the wrong way. So let me just talk to you a little bit about the things we can do easily. What can we do? Low-hanging fruit is what I decided to call it. This is a QI kind of term you may be familiar with. First one is just, let's start screening. If we don't screen, if we don't measure it, we are not going to know there's a problem. And we've started screening in many, many centers across the United States, and the reception has been really amazing. This initiative led the CF Foundation to fund 80 CF centers with a mental health coordinator for 2 years, and with plans to sustain that funding afterward. 80 CF centers got money for a mental health coordinator, and a great many of them chose to hire a clinical psychologist for their team. So this is really, after 30 years, the first time that I'm seeing my profession integrated into CF care. In other centers, they have given the social worker more training, or hired a social worker with a master's and more counseling experience. But every center got to decide and design on their own program. So the first thing is that the foundation has responded in a remarkable way, and we have begun annual screening. They are going to put out an RFA and fund additional numbers of centers in August. So if your center was not funded yet, they should really consider this initiative. My second low-hanging fruit is providing simple education. What do you need to be aware of? What should you look for? What does depression and anxiety feel like? And simple things you can do, and I'm going to suggest a few of those as well today. The education is a low-hanging fruit. And the mental health coordinator is the other issue that I think is amazing. The CF Foundation has taken these data seriously. They help to fund the International Guidelines Group, and they're actually taking that step to put mental health coordinators into CF centers. And finally, paying attention to the screening data. Once we get screening going, we actually need to do something about it. We have to pay attention to it. So this is what we're doing. This is an iPad in my clinic, and if you're worried about infection control, I realize this very simple low-tech strategy, a gallon Ziploc bag. You can put a gallon Ziploc bag around an iPad, and anybody with CF can take the PHQ-9 GAD7, and it's disposable. It costs about 3 cents. So we were concerned about infection control, but we solved that really quickly. And this is, you won't be able to see it, that's PHQ-9. It literally takes less than 5 minutes to do both of these screening tools. We've developed a whole toolkit, which is, I think, on the website of the CF Foundation, but we are sending this out to mental health coordinators, just simple information about anxiety and depression for the staff, for the multidisciplinary team, and for patients and families. Now, what would my high-hanging fruit look like? These are tougher things. These are things we're going to have to work harder to implement. So what are these? One of the issues I'm interested in is prevention. And that's in our guidelines, that we must do more prevention. Education is one aspect. But one thing we've not addressed in the CF community is preventing anxiety during painful medical procedures, beginning in preschool, beginning in early childhood. We have very good evidence-based strategies. Clinical psychologists know these very well, for helping children get used to blood draws, PICC line insertions, IV insertions, painful medical procedures, teaching them relaxation, magic tricks, ways to go to a beautiful place in their minds, so that they can cope with these painful medical procedures in a more adaptive way. And we believe that prevention on this level will keep those children from developing anxiety over time related to these painful medical procedures. That's a high-hanging fruit. Training the mental health coordinators in CF. As we begin to hire psychologists into our CF teams, we need to educate them about CF. Just like the presentation earlier, all the different medications available. Learning the basics of CF for a psychologist who's potentially been working in cancer or diabetes or another area. So that's another piece we need to do. Training our psychologists and social workers in evidence-based treatments to address anxiety and depression. We have very good treatments, brief, evidence-based, just like we use treatments to treat the physical health symptoms of CF that are evidence-based, we have psychological treatments that have a strong evidence base as well. So training our mental health coordinators in these treatments and training physicians in the CF Center, pulmonologists, to prescribe antidepressant medications, helping them get more comfortable prescribing them, because often that individual may not be going to their primary health care provider, but may depend on that care through the CF Center. And what I did in my clinic for my pulmonologist is I laminated this chart that we put in our guidelines group about the really common first-line antidepressants to try and things to watch out for. The other thing that's important is that with those new gene correctors and potentiators like Kalydeco and Orkambi, there are drug-drug interactions between those medications and antidepressants, which actually makes them less strong. And we need to train physicians in sort of being aware of those so that they are able to dose appropriately. So we're doing a lot of these kind of short courses at NACF and other mechanisms to build this training and education into our community. And finally, for parents, we need to build a referral network out into the community. Many parents in my center in Miami travel many hours to the center. So finding community-based mental health providers, and the issue is they might be excellent at counseling, but they may not know about CF. So training them in the basics of CF so that a parent caring for a child with CF could go have a few counseling sessions and not have to spend an hour explaining what CF is. So they could go there and feel they're understood, that the psychologist has good training in the basics of CF and understands the challenges that family is facing. So those are our very ambitious goals for the future. So this is one of the things I want to talk about, what to do. So this I already explained, prevention of anxiety in our youngest patients. And it's all of these painful medical procedures. So again, psychologists are very well trained in these. I wanted to show you, and I don't know if you can see this, but this is my screening data, my results to date, like hot off the press, where I'm screening at University of Miami and St. Mary's. This is a lower socioeconomic community, many Hispanic patients with CF. And so what you see here is, look at this, 47% of our adult clinics so far, we've screened 106, are depressed above the cutoff, 42% anxious above a cutoff. These rates are higher than we saw in TIDES, and the reason is we're using better tools now. 10 years ago, we didn't have these tools available. And by the way, they're free and translated into every major world language. Now, look at my teenagers. We've only screened 24 thus far, but 58% are depressed above the cutoff and 42% above the cutoff on anxiety. We have an issue in our center, and I am so glad that we are beginning to uncover it and address it. And finally, parents, we screened about 31, and again, very similar, 45% are elevated on depression, 52% on anxiety. And this is very, very important. We have had about 3% of our patients and our parents endorse suicidality. So 1 parent did, 5 adolescents did, and 3 adults. Now, there was a lot of debate about whether we should include that item in the screening. People were very afraid to include it. But then Bruce Marshall at the CF Foundation, I said to him, could you look into the registry and try to come up, kind of look at how many patients died in a particular year because of explicit suicide? Not a covert, like just giving up, but actually where it was marked in the chart. And it was really astonishing. It was about 1.5% of the deaths could be attributed to that. That woke him up to the actual importance of considering this item and addressing it. So, you know, when someone screens and ticks off that mark that they might have feelings of suicidality, all we do is check in with them and see whether, in fact, they have a plan, how serious is this issue for them. And we often find that it's just that they're feeling really down at the moment. But we have uncovered some adolescents who were cutting themselves. The team wasn't aware of it, the parents weren't aware of it. And of course, this was kind of a cry for help, but these teenagers were covering up these symptoms. And so again, if you don't measure it, just because you close your eyes and you don't see it, does not mean it's not going on. And why shouldn't we address the whole person and really take these issues on board and provide counseling and support for people who are having these feelings? Now I want to just show you that depression is linked to adherence. This is a study of enzyme adherence, and it's going to, I think, surprise you and perhaps distress you. It's published in Pediatrics. It's 88 families at 3 CF centers, and you can see the mean age of lung function, the income of families. 30%, 1/3 of these moms scored above the cutoff on a depression measure. So we were kind of shocked by that figure as well. Then we monitored enzymes. How often did you open the enzyme bottle? And this records the date and time of every single bottle opening. And so it was an electronic method to actually measure adherence to enzymes, which we've always believed is very good in CF. We've always had this myth that, of course, they take their enzymes because otherwise they'll get a stomach ache, they'll be on the toilet, there's an immediate consequence, it's just an oral medication. But no, we actually need to address adherence to enzymes. There are a lot of social situations in which taking your enzymes means you feel different, you stand out, people ask you, what are you doing? And you may not want to disclose that you have cystic fibrosis. And so you may not take your enzymes in some social situations. So we were really interested in a better measure of enzyme adherence. So we used the CF Foundation guidelines, and here was the shocker. At home, enzyme adherence was only 46%, and at school, these were centers where the child had to go to the office to pick up their enzymes. It was 86%. I wish it was higher at school as well. You know, they're getting, on the way to that nurse's office or the desk, they're getting waylaid and probably just going to the lunchroom. That's probably what they're doing. So we found 30% scored in the range, and we looked at age and enzyme adherence. And these are our youngest little toddlers to our more sort of 12, 13-year-olds. What you see is a pattern we see in adherence research all the time. As you get older, adherence goes down. And we even see this in this sample of birth, well, it was 1 year to 13 years. And we see that enzyme adherence is better when they're much younger, but as they move into school and parents have less control, it goes down. We also found that if you were depressed, you were much less likely to open those bottles. And in case you don't trust my bottle cap, in case you're not sure it's real, we saw a very nice correlation between the number of bottle openings and weight gain at the next clinic visit. So 3 months later, if you were not opening the bottles, that child had a loss of weight or did not make an expected weight gain. If you were opening the bottles a lot, then that child would gain weight at the next visit. So we put this whole thing into a complicated statistical model and showed that caregiver depression, in fact, did affect enzyme adherence, which then affected weight 3 months later. So this is the first study to measure adherence to enzymes electronically. All the others were self-report. And if you ask a 12-year-old, are you taking your enzymes? What does the 12-year-old say? Oh yeah, of course. If you ask an adult, are you taking your enzymes? What do they say? Oh yeah. And how are your GI symptoms? Oh, they're fine, same as always. So again, we need to measure these things in different ways. It is the first study to link caregiver depression directly to adherence in CF. Beth Smith and I also published a study on airway clearance that linked depression to less adherence to airway clearance, and the first study to establish the short-term link 3 months later to a very important health outcome, weight gain. So now I want to talk a little bit about the parent-child relationship, and I'm going to try to make sure that I'm not running over on time. I just want to talk about time demands and the marital relationship, because I know we have families and parents here. We studied role strain in 66 couples. Half had a child with CF. The kids were 2 to 6 years of age. And we looked at the division of household and child-rearing tasks and other things. We found in the couples who are caring for a child with CF, there were higher levels of conflict about child-rearing, more frustration in their roles and division of parenting tasks, and fewer positive daily interactions. Wives reported highest levels of stress, and the other issue was the division of child care. What we found was that moms were taking all the responsibility for caregiving tasks. And we saw this pattern continue into adolescence. Dads were doing less of it. But we also found when we talked to mothers and fathers that dads said, you know, I do want to help more. But she feels like I don't do things as well as she does. She's kind of a perfectionist. And so moms would take back this responsibility even when, and I see many of you nodding your heads, this is a very common pattern. Dads would want to take more responsibility, but moms would say, oh no, the way I do it, I sort of want to make sure I do it right. So one of my messages to all of you would be, you know what, let go of some of that perfectionism, because the benefits surely outweigh the costs. If a treatment isn't done perfectly, your husband will learn over time, and it's so important that he wants to be engaged and helping out in that CF regimen. We also found, importantly, that families caring for a child with CF had less time for recreation, and that seems to be an important message. So share caregiving responsibilities. Dads need to be more involved. Moms, you need to be willing to allow them to be more involved. And message to parents, caregiving is really difficult. It's difficult when you have a child who's healthy. I've raised 3 kids, it's difficult. Feelings of depression, anxiety are normal responses to this difficult situation. So here are some suggestions. Multitask. Cook dinner while you're supervising a VEST treatment. We showed, and I won't have time to show it today, that just being in the room with your adolescent meant they were more likely to do their treatment and do it for longer if it was an inhaled antibiotic. Remember to take time for yourself and with your partner, special time for you as a couple. Seek tangible support from healthcare providers and friends, grandparents, extended family, and seek therapeutic services when needed. Okay, I'm going to kind of skip over adolescence because I'm running out of time. But let me just give you the bottom line. Your relationship with your teen is so important, even if developmentally they seem to be pushing you away. They do that. That's just adolescence. You are a key influence on your teen's behavior. Teens were more likely to do homework if a parent's in the room, and they're more likely to do their treatment. Just being in the room increased adherence. Parent-teen relationships were the best predictor of adolescent adherence, and adolescents, when you ask them about a reward for doing a treatment, do you know what they asked for most often in our study? Special time with a mom or dad. Time where mom will just go with me shopping, or time where my dad takes me to like the game arcade or plays a video game with me. The reward the adolescents wanted most often was not a tangible reward. It was special time with a mother or father. So I'm really quickly going to go over set aside time for yourself, stress management, work on realistic goals, just small steps. Small changes lead to big effects. Treat comorbid anxiety and depression. This is good for all of us in this room. Make sure you do one relaxing activity for yourself each day. Could be a hot shower, a run, some time to do meditation, deep breathing, even if it's 5 or 10 minutes. Share your stress with others. Make sure you have fun time in every day, and spend more time in recreation with your family. I wanted to note that CFRI is on the cutting edge of all of this. They offer a mindfulness-based stress reduction course, amazing, 8 weeks online by Dr. Desh. And they have the monthly CF Caregiver Support Group. This was all mentioned earlier by Sue. But I think this is remarkable that this organization has taken on this issue and is providing all of you with resources. I wanted to tell you about a study we're calling ROSES that you could participate. This is raising optimism, strength, expectations, and success. We have noticed in our data, in lots and lots of patients, that teenagers and adults who have more regimens, more medications and treatments prescribed, some of them manage to do it at a much higher rate than people who have fewer treatments. They have some sort of amazing resilience. And so my graduate student and I are doing this ROSES project to uncover what are the resilience factors in these adolescents and adults who manage to fit these treatments in every day, even though they have the highest number prescribed each day. And that's the whole focus of ROSES. And there are little postcards about the study. Now I'm hoping this film works, because what better way to end than to show you Kat Quinn, who is a parent caring for a child with CF, and I hope it works. And this video was done at the plenary, and we went out to her home and did the filming, and she is just remarkable. I don't know how to do it. Maybe you can help me. I mean, this is where my technology background fails me.
You should be able to.
I'm not sure he's probably going to get it to work.
Should.
We tested this.
We did.
You know how that goes with technology. This is a remarkable little clip for you, if we can get it to play. Won't play.
Hang on.
My name is Kat Quinn, and I have 2 children. My oldest is Navy, and she has CF, and my youngest is Elsie, and she does not have CF. I had a very different experience than most families because Navy was diagnosed at 3. And so those first 2 years of her life were very terrifying, trying to figure out what was wrong with her and not having answers. And so when Maylee was diagnosed, while cystic fibrosis was a terrifying label to be given to her, there was also a feeling of relief that we actually had a place to start working now. We had treatments, we had opportunities to help get her back to being healthy. The emotional aspect of CF is probably the most impactful aspect of everything. It's that feeling of being out of control, not being able to fix something. No one can go through what we go through every day, watching our children in pain or struggling to breathe or being the one to hold them down for a procedure and not feel some sort of anxiety and depression. There would just be nothing in you if you didn't feel that. And so it doesn't matter how amazing your support system is. It doesn't matter how amazing, all the other moments in your life are. There are these key points within the CF life that absolutely rip you apart. With all the hurdles that we have, that if you're not healthy, you cannot take care of your children. And I think that needs to be the focus.
Uh-oh.
We are the role model for how they'll be caring for themselves. I think that mental health screening for both patients and caregivers should definitely be something that should start.
Okay, well, I think you
Having support systems in place that allow for caregivers to really unload about what that feeling and have ideas as to how to kind of push through those times, right when those first clinic visits happen, that it's just implemented into part of the routine maintenance. I mean, how's your lung function? How's your BMI? How is your mental health as well as your child's? Just to kind of have that screening be a part of all the other screenings that happen, so that when a red flag comes up, it can be addressed in a very non-confrontational environment that makes everyone feel like it's just part of the care. I think normalizing the emotions that accompany the diagnosis and the disease progression is first kind of point to get back to where I need to be the best caregiver for me.
Ooh, we sort of got through that, right? Just a little bit? Vaguely. Okay, I just want to say that she said it better than I could ever say it, and that is making mental health just part of one of those other screenings we do. You check your weight, you check your height, you check your BMI, and you check your mental health. So thank you so much, and I'm happy to take any questions. Oh, sorry.
Okay, just remember, use the microphone in the center of the room. Please limit yourself to one question per person because of time. And when asking a question or a comment, please speak into the microphone. The microphone is set up in the middle of the room, and remember to allow the volunteer to clean and adjust the microphone for you.
Thank you.
Hi, my name is Maggie O'Connell. I'm a mom of an adult child with cystic fibrosis, and I want to say thank you.
You're welcome.
Thank you very, very much. My kid is 23 and had a small part, half, or whole of what you've been talking about that are now available for newborns and newly diagnosed been in place, things would be very different. And I feel like the elephant that has been in the room for a very, very, very long time is no longer an elephant. And I felt it as such in all the years in clinic when she was a youngster. And the funding that you were able to get has directly benefited her. She's at a UCLA care center, and she said that she had a CF trained, a psychologist trained in CF. And it's the first time she felt that she's been understood. And I just want to say thank you for that. And I wanted to know, in terms of a rollout, is this something that you're going to try to bring into all CF centers as for the the early visits and the initial visits as part of the the whole care, the whole person care?
Well, first of all, thank you for saying that as a parent, that this has been the elephant in the room, because it has been very hard to talk about these very normal feelings. Feeling discouraged, feeling down, feeling as a person with CF that you just spent all day doing those treatments, and when you wake up the next morning, you are going to have a whole list of treatments to do again the next day. And it has been hard to bring it into the conversation because we're really on that frontier of integrating mental and physical health. We will be the first organization, although this has been in the care guidelines for teenagers with diabetes for a decade, for asthma screening, other chronic conditions have advocated annual screening. No one has implemented it. The CF group the CF Foundation will be the first national organization to actually do it. So thank you for just recognizing this is an important part as you take this journey. Addressing these symptoms can be just part of going to your clinic visit. Yes, the 80 centers who were funded have 2 years of funding with a plan to, or 3 years, I believe, plan to extend it. They had to write that into the grant. And they're often hiring psychologists. And there is somewhat of a difference sometimes between the training of a PhD psychologist and a social worker. And psychologists have been trained in these evidence-based treatments. So yes, it should be part of whether you have a newborn, you should be screened as a parent. And you know in every primary care clinic, you're supposed to screen postpartum depression. And that's become part of guidelines too. The American Academy of Pediatrics has said that all adolescents, whether they have a chronic illness or are perfectly healthy, should be screened every year for depression. So we are actually beginning to embrace what has been out there, but actually making it happen. And the fact that you could talk comfortably about these feelings with somebody is really a critical part. So I thank you for your comment and for your question.
Thank you also. My name is Robin, and I have a daughter who's 35 with CF. She received a double lung transplant when she was 29. And I've been involved and connected to CFRI ever since her diagnosis, so for a very long time, and have been able to experience the CF world and our culture for a really long time. There's a couple things I'd love to mention, and one of the things about CFRI is that we've been able to come together as a community. And that's one of the things that I saw missing in the things that you had listed, that I think for this community has been essential to our mental health, of being able to come together with people who experience the same thing, be able to talk, meet, make friends. That's not only of us parents, but also of, and for my daughter, it was when she was little, there was camp. Of course, there is no camp any longer. But that was essential to her ability to be a whole person. We also, but now in today's world, we do have a CF adult retreat that meets every year with very strict guidelines, and the spirit of camp is able to continue with adults with CF. I also wanted to mention that I've been able to start a mother's retreat. We've had 2, and we will have another one next year, and the coming together of about 30 mothers together to be able to share their stories and receive support and find friendship has been really, really important too. And so I just want to thank you for all the work that you've done, because it's been very, very important and has not really been acknowledged until very recently of how important mental health in this disease is to the outcomes of our kids and to ourselves.
Of course,
You know,
to ourselves.
It's really important that we as parents and caregivers are able to be healthy and whole too.
Well, I thank you for your comments and the fact that CFRI is really on the cutting edge in addressing this, and the fact that there's a conference like this that people with CF with strict guidelines can attend. And I was a psychologist in the days where Family Day, I would run a group for adolescents with CF. We would have camp. We would have all kinds of groups where we could bring young children and teens with CF and adults together to share commonalities, to share coping strategies. And infection control guidelines, as we know, have really eliminated those opportunities and left kind of a gap there to fill. And I think that, of course, the screening is one effort to address that gap, but what CFRI is doing is absolutely another gap, because peer-to-peer support is probably one of the most important strategies for all of you. Meeting other parents like you, meeting other people like you, because I don't have CF. I am not the most credible source in the room on what it's like to get up every day and deal with it. I can't be. But you to each other can provide that level of support that is really critical and unique. It's not provided by anything else. So I really have to thank CFRI for being willing to stand out and be such an innovator in the CF space.
Hi, my name's Kristen. I'm a respiratory therapist locally, and I just wanted you to address first of all, I want to embrace all of the changes that have come about and how helpful it is to have the screening, and where our clinic is participating in that. But the resources are there, and the counseling is available, but we're having a really hard time getting families to engage.
Yes. Follow through is probably for all of us the most difficult thing. And I think with mental health especially, first of all, if you're an individual with CF, you have so much to manage in your day already. We need to provide things in the easiest, most efficient format for you. So it may be an online mindfulness course. It may be an online CBT depression course. We're actually testing that phone-based and computer-based because you have busy lives as adults. You don't have time necessary to come in, or would you want to travel into your CF center? So the screening can take place, maybe some brief counseling, and what we want to test, we actually have a grant into the foundation, is a few face-to-face meetings and then doing everything by phone or Skype to increase that follow-through. You're exactly right. Parents as well. We refer them into the community, but it's hard to get them to follow through. First of all, this is a change in our culture to begin to think that this has a direct and important impact on managing the disease. That's a change. We focus so much on treatments and adherence and getting to clinic, but we haven't focused as much on treating the emotional side. So it's a change in our culture. It's also not that easy to access mental health in our communities. I mean, to be honest, the United States is way behind on this. In Europe, every single CF center in most of the major European countries has a psychologist there already. They've been there for decades. So again, mental health in this country is often not covered. It's often harder to access, and it takes more follow-through from parents and individuals with CF. So that's some of the culture of the United States. I don't think I'll be able to change that. It's going to take a long time, and insurance companies understanding I could reduce exacerbations, and that costs a lot of money if I provided some of this counseling, but this is a fight that probably will go on for a long time. Hi there.
Hi, Alexandra.
Hi.
Listen, I really want to congratulate you on your success here.
Thank you.
It's fantastic.
Thank you all. Thank you.
It's something we've needed for decades, and you've pushed through, and good for you.
Thank you.
Now let me put you on the spot.
Go ahead.
As you know, over the last 3 or so years, the Cystic Fibrosis Foundation has put out an enormous amount of literature and guidelines with respect to cross-contamination. And although that's done with the best of intents, it's had some very serious unintended consequences, which have led to labeling, to fear, to stigma, that's created an enormous amount of at least anxiety, if not depression. So the question is, what do we as patients with cystic fibrosis, or people with cystic fibrosis, and parents who also suffer from the same kind of fear, handle this? From the mental health point of view, what are you guys suggesting to us?
Well, this is really the same kind of question. It's a critically important one. We should have been studying mental health before infection guidelines went in and became rather draconian. We should have understood what that peer support meant for our patients. I used to do summer camps. I did all of this, and now none of that. I'm not able to bring patients or teenagers or adults together. So we should have done that because these are unintended consequences. You know, it was infection control specialists and pulmonologists and physicians, and with the very best of intentions, they want to reduce infection risk. I understand that, and it's very legitimate. And there were data that alarmed people and made them feel that this was very important, but it has had unintended consequences. There aren't really simple solutions. I think some of them have to be internet-based. In other words, drawing together people who are like-minded, individuals with CF who are adults, young adults, or older adults, or adolescents, and providing some way for them to communicate online, support groups. However, I did a study with adolescents using online support called CF Phone. And it was, as I populated the internet, the chat room, the NIH asked me to monitor all the chat dialogue every 48 hours. They were afraid of two things. One, misinformation being communicated from one adolescent or young adult to another, medical misinformation. The second was that there would be people super depressed on that website who would be in crisis. And the first thing didn't happen. No medical misinformation. Actually, they shared great information back and forth, like an adolescent said, my enzymes expired a month ago. Should I still take them? And what do you think? All the peers wrote back and said, no, they're expired. They're not going to work as well. So medical misinformation wasn't an issue, but the online support group was a number of very, very depressed adolescents, often in rural communities, joined the website. And I had 2 or 3, I was in my backyard managing suicidal cases of adolescents in different parts of the United States where there was very little access to mental health. And so one of the things that concerned me was having supervised chat, especially for adolescents. Maybe adults don't need supervision, but it looked like the teenagers did need monitoring and supervision, which takes away the spontaneity of getting on there and chatting at midnight or early in the morning or while you're doing a treatment, because you would have to have an appropriate professional online. But it's just something I learned by doing that study. So I don't have easy solutions. I think what CFRI is doing is great. Having this kind of meeting is amazing, somewhat controversial, but amazing. It fills that gap in a very important way. Thinking about using online resources. All kids are wired with cell phones, we know now. They're all on the internet. This is one way we can access other people like ourselves. And then being aware that for some vulnerable people, there needs to be some professional support on there to monitor how things are going. Parent support groups, I think, are quite doable. I mean, there's no problem with parents getting together, and this, I think, is a critical type of support. Thank you so much for that.
Thank you. My name is Laura. I'm an adult with CF who was diagnosed late, but I want to thank you for your persistence in making all these things come through. But my thoughts are for those of us who come late into the CF community. I didn't have a mother, so I'm not worried about her, but what about our spouses and partners and children? Is there anybody, you perhaps, looking at that, or will there be future research in that area? Many of the things you said caused me to pause and say, oh, perhaps we all have some work to do too. So thank you.
I think that's a great question for late diagnoses. And this is a more recent phenomenon where we're able to genotype and we're discovering people who didn't have sort of classic CF and weren't identified early. And you might feel somewhat different than those who have been living with it all the way along. So I think some of those same guidelines and paying attention to your mental health, sharing with your partner, making it part of and integrated into your daily life, and then accessing support from others who are also in a similar situation. I don't know of anybody really studying that at the moment. I think it's a great question and something that we should think about. One way we'll be able to look at that is as we hopefully put these screening scores into the CFF registry, which is one of my next dreams, is that we can look at late diagnoses. And we can look at what are the risk factors for that subgroup who are diagnosed much later in life. What are the risk factors for them having more symptoms of depression and anxiety? So once the screening is going on, and once I can convince the foundation to put the scores in the registry, we could actually mine that data to understand what is important for those patients and begin to address those risk factors.
And our independent children and spouses, I think we're less dependent on our family to help us with what we need to do but I do think they're impacted and
Absolutely. This is
wanna
a
bring them
system.
along.
Dude, there's absolutely no way that an adult partner, spouse, is not affected if you're diagnosed with CF. It changes your lifestyle. It changes your priorities. It means you have to fit this regimen in. It raises your anxiety level. Anyone in that family system will be affected. And I didn't have time to show you the effects on healthy siblings, which we've also studied. So yes, we need to think of this as a system, and we need to address all the members of that system because they're all affected. Yes.
Yeah, I think this is just so phenomenal that you're doing this because it's a very big piece of what's needed in the clinic settings. When you're first diagnosed, when you hear that diagnosis, it's overwhelming. And then
Yes.
when we showed up when I went to the clinic visit, I was told, "Oh, just take him home and treat him like a normal baby." And it's like, no, that's not good enough. I'm depressed. I don't know enough information. You're not able to give me enough information. And so you do have to take a look at where people are in their mental health. And then, your thoughts are, well, I'll just find another parent, and at least I have somebody that understands, and then our children can play together. Then you learn, oh, no, they can't. You can't be in the same room with somebody else that has it. And so the best thing that ever happened for us is that we found CFRI, and I went to a conference, and I mean, it was like life-changing.
Right.
Life-changing, just being here with these folks.
Right.
They're so embracing and so knowledgeable, but still, a lot of them, they have children that are older. I've yet to be connected with somebody that's got infant, to try to figure out, well, things that come up with infants, what do you do? And then also, when you have infants, a lot of time you have other children. So what about those children, I think it's something that needs to be checked in on every visit. And you have a social worker on board, and so I could never understand, well, what is the purpose?
Right.
I mean, I'm just saying, things haven't fitted for me, as
Right.
far as when you go to the clinic, whose role is what, and then being new and you don't have other people to ask questions, then why can't you get phone numbers for each individuals and talk with them, so I'm happy that you're taking a look at the mental health, how people are being talked to, because a part of it's going to be how people are being presented information and things like that too, and how
Right.
that makes them feel.
Well, you've mentioned a number of amazing things. First of all, we should have a mechanism in CF centers to connect a parent newly diagnosed with another parent who's more knowledgeable but in that same stream of developmental life, who could provide guidance. And I think that we did that at my center at Riley in Indianapolis. We had a set of parents, kind of the parent advisory group, but some were very knowledgeable, coping well, and very able to respond to questions from a parent in that first year of new diagnosis. That is a critical period of stress, anxiety, depression, isolation. I've shown it in several studies that this is a very high-risk period, and infusing those early parents with support could get them on a much better path going forward. So that's an amazing thing that I think we should really work on. In terms of the role of the social worker, to be honest, the social worker in a CF team has often been a case manager. That person's helped you get medications or insurance or managed a hospital visit or equipment. And that person's time has been literally just booked up with all of that. And there hasn't been a focus on the mental health side. So this new initiative of and that person will be called a mental health coordinator, and in many centers it will be a psychologist, a PhD level, then that person now has a role on the team to really monitor and guide mental health resources. And so the social worker has just been stretched too thin, trying to provide those basics and not really able to address those other issues. So those are my two suggestions. We need a role like that, someone who is overseeing mental health, and can also go visit a person in the hospital who could follow through and develops a relationship with that person over time. That is very important. And also this peer-to-peer parent support in the first year of life. I honestly think that we should find some mechanism for it. And it is happening at some centers, but obviously it's not happening at all. And that takes a bit of work and organization on someone's part on the team. So I know I'm way out of time, so I just want to thank you so much. It's been wonderful to speak to you. This is what keeps me going, talking to people like you, and I thank you so much.
Jim, can I just say one thing?
No. I've wanted to do that for so long. Yes, go ahead, Siri.
This is just the beginning, Jim. I just want everybody to know that Dr. Quittner has generously offered to stay tomorrow for our Ask the Experts panel. I know there are many, many more questions. I had my own list here. So, and I know many of us are wondering more about the healthy sibling issues. So I just want to give everybody just to know you will have more opportunities to ask tomorrow.
Great, thanks, Siri. All right, let's take a minute now and stretch our legs.